In this episode, I'll be speaking with Dr. Sadikah Behbehani about endometriosis. Endo is a chronic condition that impacts about 10% of women and prepubescent girls, often causing intense discomfort and pain, and in some cases, infertility. We discuss common symptoms of endo as well as how to receive a proper diagnosis and, of course, how to treat endo and improve a woman's quality of life. And that is the good news. It's treatable. This is an extremely important women's health episode, so please pass it on to the women in your life, especially anyone that you know that is experiencing severe pain around their cycles. Dr. Sadikah Behbehani is a double board certified OBGYN who specializes in reproductive endocrinology and infertility, as well as minimally invasive gynecological surgery. She currently practices at the Center for Endometriosis and Fertility in California and is an associate professor at the University of California, Riverside. Dr. Behbehani is a specialist in endo and is one of the few surgeons that focuses her practice on fertility-sparing excision surgery. She trained with the pioneers of endometriosis excision surgery at the Mayo Clinic and is an expert in robotic surgery as well. Dr. Behbehani has also published hundreds of articles related to endometriosis and is often invited to speak at national and international conferences, educating fellow physicians on the complexity of the disease. Dr. Sadikah, thank you so much for being here with me today. I'm so looking forward to this conversation about endometriosis. How are you?
I'm good. Thank you so much for having me here. I'm really excited about this. I think what you're doing is great. We need to keep raising awareness about the topic, and I'm happy to help educate women.
Thank you for saying that. I feel the exact same way. And this, I have to admit, is not a topic I know a lot about. And it's not something I share a lot about on my socials. So I'm really excited to have an expert like you really help me do a deep dive. So I guess to just start simple and basic, I'd like to ask you the question, what is endometriosis and how does it impact the body?
That's a great question. Endometriosis is often misunderstood, so I'm happy to clear some misconceptions and explain the disease in a way that makes it simple for women to understand. Endometriosis is actually more common than we think it is, so before going into the definition, I'd just like to say that about 10% to 30% of women will suffer from endometriosis. If we're looking at the infertile population, about half of them will have endometriosis. So if you're sitting at a fertility office, about half the women in the room will have endometriosis. And this is why it's a very important topic that we need to discuss, because a lot of the times it gets misdiagnosed or misunderstood. And so the actual definition of endometriosis is the presence of tissue that is similar to the lining of the tissue outside the uterus. So every month, when a lining of the uterus sheds in a period, women get a menstrual cycle. When that lining of the uterus or cells that are similar to the lining of the uterus form implants outside the uterus, those implants can also shed and bleed every month in response to hormones. But because they're not within the cavity of the uterus, they can't shed that blood in a way that makes it exit the body. So in a menstrual cycle, the lining sheds and women bleed and that cells come out. But in endometriosis, those implants that are made of cells that are similar to the lining of the uterus, they can bleed and cause inflammation because there's no way for those cells to leave the body. Endometriosis, like I said, is the presence of that tissue outside the uterus. So where can it be outside the uterus? Literally everywhere in the body. It could be on the diaphragm, which is the muscle that helps us breathe. It could be on the bowel, which is what it creates that stool content and helps us defecate. It can be on the bladder, which is the organ that holds urine and helps us urinate. It could be around the ovaries, around the tubes, around the appendix. It can be anywhere. And so women who have endometriosis, usually the most common symptom is pain, but not everybody who has endometriosis has pain. The reason why I mentioned that it's a very important condition to discuss and the prevalence of it is pain gets dismissed very often. So women, when they mention they have pelvic pain with their cycles, a lot of the time they just get told, oh, it's a bad period. Don't worry about it. You'll outgrow it. Or even worse, just get pregnant and it'll get better after having children. But no one ever, or very few people actually put in the work and effort to investigate and see why this woman is having painful periods and whether it's endometriosis or not. Because if it is endometriosis, it is treatable. Women don't have to suffer through pelvic pain. And we talked about statistics when we're talking about pelvic pain patients. more than 90% of them will have endometriosis. It's a very easy referral. Find an endometriosis surgeon or an endometriosis expert and see them if you have pelvic pain. Because there's a more than the 90% chance that your pelvic pain is endometriosis. And endometriosis is treatable. Women should not have to suffer. The quality of life should not have to be compromised because of their pelvic pain.
I'm so glad that you said easy, you said treatable, and that our lives don't have to be compromised with this. Is it a disease? Would you call it a disease or a disorder?
It is. I would
It's a
call it a
disease.
chronic disease, actually. So once women are diagnosed with endometriosis, we consider that a chronic diagnosis, just like when we diagnose people with high blood pressure or with diabetes. We can say their diabetes is very well controlled on medication and they no longer have abnormal blood sugars, or we can say the high blood pressure or hypertension is well controlled on medication. So same with endometriosis. Once you get a diagnosis of endometriosis, we consider that a chronic disorder. However, once we treat it and excise it or remove it, and we'll talk about the treatment, then you'll always have to mention that you have history of endometriosis, but it was treated. And that's what we want for our patients. It's not just to say, I have pelvic pain and I have suspected endometriosis, is we want our patients to be able to say, I have endometriosis and it was treated.
So I get really excited about that because I have come across women, both in my personal and my professional life, where there's a very deep held belief that this is not something that's treatable. It's something that they have to live with for the rest of their life, or they have to be on medications for the rest of your life. So I am so excited to hear that it's something that women don't have to live with and that it's treatable. Before we get into treatments, I'd love to first understand endometriosis a little bit more because you're talking about this tissue that is growing outside of the uterus as far as the diaphragm and even probably in more random places in the body, places that you wouldn't think a woman would be growing uterine tissue. So when we're having a cycle and you're saying those areas are bleeding, where does the blood go then? And is this the cause of pain?
That's a great question. Absolutely. So the blood has nowhere to go. It gets stuck in the tissue. It causes inflammation and scarring, and that's what causes the pain. So when we look at that tissue, the endometrial glands and stroma, visually with our eyes, they may appear different. We may see them as red flame lesions, which are more common in adolescent and young girls. We may see them as clear vesicular lesions, or they may appear like powder burn blue-black lesions. The powder burn lesions are the most common presentation of endometriosis. Studies have shown that we are wrong 50% of the time, meaning that if I see a spot that looks really concerning to my eyes and suspicious for endometriosis, I cut it out, I send it to the pathologist. The pathologist may say, nope, this is just scar tissue or this is just inflammation. Whereas if I see a spot that may look normal to my eyes, it just looks like normal tissue, I cut it out, send it to the pathologist. Again, there's a 50% chance that they come back and say, this tissue has endometrial glands and stroma. And so we have to have surgery with an experienced surgeon, and we'll talk about the surgical procedure itself. But the way those lesions look like is hard to determine if they're endo or not without actually cutting it out and having the pathologist examine it under the microscope. Because when we talked about the diagnosis, I said it's the presence of endometrial glands and stroma. Endometrial glands and stroma are not things we see with our naked eyes. They're glands and stroma that are seen under the microscope with a pathology specimen. And this is why the only way to diagnose and confirm endometriosis is surgery. We can suspect the endometriosis based on symptoms, and like you mentioned, some women are on medications or on hormones for the symptoms of endo, but the endo cannot be confirmed unless we do laparoscopy, not just to look for it with our eyes, but to actually cut it out and send the specimen to the pathologist to review. Because again, I hear about women having surgery where it's just diagnostic. They pop a scope in, they look around, and they say, yep, we found spots that look like endo. But did you actually cut them out and have the pathologist confirm it's endo? And if the answer is not, then you did not have an appropriate diagnostic surgery for endometriosis, because there needs to be tissue evaluation for diagnosis. It's very similar to cancer, right? No one ever says you have cancer just based on imaging. We can say we suspect you have cancer based on the ultrasound or the CT scan, but there always has to be a tissue diagnosis to determine what type of cells are producing the cancer. And so it's same with endometriosis. We can see signs of endometriosis on imaging like ultrasound or a CT scan or an MRI, We can suspect endometriosis based on symptoms, pelvic pain, and infertility, but we cannot confirm the diagnosis of endometriosis without surgery and a pathology specimen.
And for women who have been living with endo for many years into adulthood, so that's many menstrual cycles, and they're undiagnosed and they're experiencing the common symptoms of pain, and they haven't had that surgery, as you said, to have that accurate diagnosis. And then you're talking about these lesions that are then bleeding with her cycle every month. Are they just collecting more and more scar tissue in the body and all over the place, and it just keeps getting worse and worse as the months and the years roll out?
Exactly, you said it. That's exactly what happens is the disease keeps getting worse and worse with time, and we cannot predict how fast the disease will progress. I see women as young as their early 20s with really bad advanced stage 4 endometriosis. And I see women in their older 40s and they have stage 1 to 2 endometriosis. So that's another thing to consider is the stage of disease does not correlate with the severity of the symptoms. You can have early stage disease and really bad symptoms, or you can have very advanced endometriosis and very little symptoms that may not even be bothersome. But you're right, as the disease stays behind and grows and festers, it will cause more scarring. The scarring leads to tissues sticking together. So we see the bowel being attached to the ovary attached to the back of the uterus. So all that scarring and what we call adhesions are very common with endometriosis that has been sitting there for a long time. The bleeding every month into the tissue creates worsening pain, and that's why women feel an exacerbation of their pain while they're on their period. However, women can still have pain between cycles, and that's how the symptoms progress, is it may start with just a painful period, but then it's the week before the period that hurts, and then it's the week after the period that also hurts, and then before you know it, women are having pain 3 weeks out of the month, or even more frequently if the symptoms get dismissed and the disease does not get treated appropriately.
You talk about scar tissue and adhesions, but I've also heard of something called a chocolate cyst. Is that part of endometriosis, and is it a completely different symptom of the disease?
It is very well part of the endometriosis diagnosis. Chocolate cysts are medically termed endometriomas. So they are endometriomas or endometrial cysts of the ovary. So when the ovary has endometriosis on it, it usually grows within the tissue of the ovary and forms a cyst. A cyst is just a collection of fluid or tissue, and with an endometriotic cyst or a chocolate cyst, that fluid within it is blood. So it's basically what we talked about with bleeding from that endometrial tissue within the organ. And when it's in an ovary, the ovary allows the cyst to grow and grow and grow. And we see endometriomas that can be really large. And we see endometriomas that can be small as 1 or 2 centimeters. But it doesn't matter how big the cyst is, because even small cysts can cause a lot of pain and can cause a lot of difficulty getting pregnant. So endometriomas or chocolate cysts are considered a form of deeply infiltrative endometriosis. So I briefly talked about the staging of endometriosis. The stage goes from stage 1 being mild to stage 4 being advanced. And the staging doesn't relate to pain. It just helps us as surgeon determine how advanced the disease is and help someone else reviewing that report to know what we found at the time of surgery. So if I say there's stage 4 endometriosis, then everyone who reads the report will automatically know that the ovaries were attached to each other, that the bowel was stuck to the back of the uterus, that there might have been 1 or 2 sides of the ovaries having cysts, so endometriomas, so it's a sign of advanced disease. And that staging system was put in place to correlate with fertility. So stage 4 endometriosis patients have a more difficult time getting pregnant naturally compared to stage 1 endometriosis patients. So we call that the ASRM classification. ASRM stands for the American Society of Reproductive Medicine. So it's a grading fertility classification, but it's a very well used or very often used classification when we diagnose the stage of endometriosis. DIE, or deeply infiltrative endometriosis, is another subset. It's another category or classification of endometriosis. So when the endometriosis grows beyond 5 millimeters of depth into the organ, that's called a DIE nodule, a deeply infiltrative endometriotic nodule. And having an endometrioma is automatically DIE. because an endometrioma or a chocolate cyst means that the endometriosis has grown deep into the ovary. And I have a series going on that I always talk about on my Instagram profile, that it's never just an endometrioma. If you see an endometrioma on imaging, then that's 100% sign that you have advanced endometriosis going on elsewhere. That ovary that has the endometrioma has already been affected by deep inflammatory disease. The ovary will 100% be stuck to something. It'll be stuck to the back of the uterus, it'll be stuck to the pelvic sidewall. Endometriosis loves the ureter. The ureter is the organ or the channel that transfers urine from the kidney to the bladder. Endometriosis will always grow and try and stick to that ureter. So we have to separate the endo from the ureter, which can be challenging sometimes in stages of advanced endometriosis or stages where the endometrioma has grown really deeply into the organ. I have had patients lose kidney function, unfortunately, because the endometriomas have blocked that ureter where the ureter no longer functions to transport urine from the kidney to the bladder. And this is why patients ask me if endometriosis is dangerous. Yes, it can be dangerous. If left untreated, it can cause organ dysfunction. Women have to have a bowel resection because of endometriosis. Women have lost their kidneys because of endometriosis. Some women have to have half their bladder removed because of endometriosis. So we never wanted to get to that stage. Ideally, we want to diagnose the disease early where we can treat it where it's still at a stage 1 to 2 or even 3 without having to compromise and lose organ function.
What causes endometriosis? Does medical science have an answer, or are we still guessing?
That's a great question. We have theories, but we cannot say one theory is more likely to explain the occurrence of disease over the other. It all depends on multiple factors. And by the time women have endometriosis, they always come and ask me, what do you think caused my endometriosis? It's really impossible to tell. But the theories are based on the fact that the endometriosis has probably been there for a long time. It's probably a disease that grows in utero. So when an embryo is growing within the uterus, the tissue is developing, the tissue that forms the uterus, the tissue that forms the vagina, we call it the Müllerian tract. So as the Müllerian tract develops in utero, there's some sort of abnormal development happens where endometriotic implants get deposited within the peritoneal cavity. And this is why we've seen endometriosis diagnosed in girls that are prepubertal. So really young girls, before they go through puberty, they have endometriosis already present in their pelvis. And we think that's related to congenital development. So as the baby's uterus is developing in utero, there's abnormal development happening where implants of endometriosis get deposited along the way.
Just to clarify for people listening, if someone doesn't understand what in utero means, it means when you are in your mother's womb, developing as a fetus, you are potentially being developed with endometriosis. I've never heard that
you're born
theory.
with it. So
you're born with it, but is that genetics as well, or is that just a disease that showed up, unfortunately, while you were a fetus in your mother's womb, or does your mother also need to have endometriosis and pass it on to you?
it may be genetic because it's likely to run in families. So I always ask my patients if their moms, their sisters, their aunts had similar pain symptoms. But it doesn't mean that the mom passed it on because she was pregnant with the embryo while she had endometriosis. So it's not transmitted through that. It's not transmitted from the mother's blood to the baby. But if the mother herself has genes that predisposes her to develop endometriosis, then it's likely that those genes were passed on to her female offsprings that then have a higher risk of developing endometriosis. So that's one theory, the developing it in utero. And yes, genetic influence is a thing with endometriosis. So if your family members have endo, you're more likely to have endo as well. But not everybody will. So I have patients who are worried about their children developing endometriosis because they have it. And then they have girls that go on to have a normal, healthy, pubertal menstrual cycle without pelvic pain or issues. So doesn't necessarily mean that you will pass it on to your female offsprings. Another theory I want to discuss is the theory that the peritoneal cavity has stem cells that are undifferentiated. So we hear a lot of research about stem cells coming from the umbilical cord. Stem cells are cells that can differentiate into anything. They have the potential to become any cell we want it to be. So there are undifferentiated cells in the peritoneal cavity that can differentiate to become uterine lining cells. in response to hormones throughout the menstrual cycle. So as women are ovulating, they're producing estrogen, and that estrogen may stimulate the growth of those pluripotent or pluripotential cells that are available in the peritoneal cavity. And just to simplify it, the peritoneal cavity is the cavity that's inside our abdomen. It's where our organs grow, it's where the uterus grows, it's where the bowel grows, where the bladder is. And so around those organs, there's the covering called the peritoneum. I like to call it the skin of the organ. So it's like the top layer that covers all our organs. And that peritoneal layer is the layer that has those undifferentiated cells that can differentiate into endometriosis cells based on stimulation by the ovarian hormones. And if that cell is on the bowel, then you will have bowel endometriosis. If that cell is on the bladder, then you will have bladder endometriosis. So it's the development of those undifferentiated cells into uterine lining cells in response to ovarian hormone stimulation. That's another theory.
Is there anything that triggers those stem cells to produce endometriosis cells? Like, is there any epigenetics that comes into this? Is there any diet and lifestyle triggers that, will make a woman more susceptible to develop endometriosis from those stem cells versus another woman?
That's an excellent question, Elia. And unfortunately, that we don't have the answer to. We always encourage our endometriosis patients to lead a healthy lifestyle because we know in science that a healthy lifestyle can reduce the inflammation or the recurrence of chronic disease, whatever it is. So any chronic disorder of the liver, the kidneys, or the pancreas, we know that those chronic disorders can respond well to a healthy diet and healthy lifestyle. And so we encourage that with endometriosis, but we don't have enough data to say for sure that women who lead a healthy lifestyle are at a lower risk for developing endo, because unfortunately, many of our endometriosis patients are young, they're of reproductive age, and many of them are healthy. And before they come to see me, many of them have tried to change their diet and lifestyle to see if it helps get rid of their symptoms. But by the time they have symptoms, the disease is there. And diet and exercise is not going to reverse that growth that has happened already. So another theory that we need to discuss when it comes to endometriosis growth is the fact that endometriosis can spread through blood vessels and through lymphatic channels, just like cancer. So you hear about women who have, for example, breast cancer, and then they developed brain metastasis. How is that tumor going from the breast to the brain, either through blood or lymph nodes? And unfortunately, the same thing happens with endometriosis. Endometriosis has been found in the brain. It has been found in the lung tissue. It has been found in the heart. And so how can it get to those distant organs? It can spread through blood and lymphatic channels. And that's another thing to keep in mind is I have women who have very strange symptoms and they ask, could it be endometriosis? And I always say it could be. We cannot exclude it just because it's in a distant organ. It can still spread through the blood channels and through lymphatic vessels.
I have never heard of endo spreading to the brain. How do you even begin to do a surgery like that or to treat the brain?
Right.
Do we now need an endo specialist or a surgeon like yourself? And then do you need a neurosurgeon to come in and also help in this procedure?
Absolutely. I am not a neurosurgeon. I am not comfortable cutting into someone's brain, but my job is to find my patient the team that can do that for them. Because how do endometriosis of the brain patients present? That's the first question, right? They get cyclical headaches and migraines, and they get brain bleeds with their period. So we talked about how those implants bleed.
Wow.
So imagine while they're on their period bleeding from their uterus, their endometriotic implants in the brain are bleeding as well. And those women will get head scans, so CTs and MRIs that show hemorrhage. It shows bleeding in the brain. And then they treat them conservatively, it goes away, and then the next month, guess what? On their period, it happens again. So that's how we develop that pattern. There's a cyclical pattern going on where those women are developing brain bleeds every month. But will the ER physician put two and two together? No, because their job is just to make sure the patient is safe and treated for this episode of hemorrhage. It's the endometriosis surgeon's job to ask all the right questions, fit the pieces of the puzzle together, and suspect the diagnosis of brain bleeds that are happening from endometriosis. So then we find a neurosurgeon who's comfortable resecting areas of the brain that may have endometriosis in them. The same thing happens in the lungs. So myself as a pelvic surgeon, as a GYN surgeon, I will definitely treat everything that's in the pelvis, and then I will collaborate with those other surgeons to treat the endometriosis that's found in distant organs such as the lungs or the brain or the heart or wherever it may be.
This is so fascinating. And in some way, it's so beautiful that the body is so intelligent that when it has those cells, it knows to bleed every single month, no matter where those cells are, whether it's in the uterus or not. But unfortunately, these women are probably suffering a lot and have to go through a lot of medical attention and surgeries, and that's probably a very difficult process to go through for them. I wonder if there is an evolutionary reason for endometriosis. I like to believe that the body doesn't make mistakes, and I've done a little bit of reading on this where, for example, diabetes is a very challenging condition to have in this day and age, but apparently there was an evolutionary reason for it, that if you elevated blood sugar, you were more likely to survive cold, so the ice age. So that's why there's this genetic component of passing down diabetes to your offspring, because if you lived in cold areas or if you lived through the ice age, you were more likely to die if you weren't diabetic versus someone who did have high blood sugar and high blood sugar concentration, the water in their body wouldn't freeze. So that's just one example of diseases showing up today that could potentially have some benefits evolutionarily. And there's a book, and I'll link it below. It's called Survival of the Sickest, and how diseases had some purpose. So I really wonder, I don't know if you've come across any theories, if endo has any evolutionary purpose or is triggered by something in our past, or is there another theory that science is coming up with that is presenting as to why women go through this, or why there is this kind of switching on genetically of these stem cells to produce these different types of tissues all over the body.
Wow, this is very interesting. I have not heard of this theory before with the diabetes, so thank you for teaching me something new today. I don't know, Alia. That's a good question. I don't know. I don't think that there's anything on the evolution of endometriosis. I think we are seeing more and more endometriosis diagnosed now because we're getting better at picking it up. Can you imagine 50 years ago if a woman said she had pain with her periods? No one would do anything about it. As long as she can have children, that's all they cared about. The women were there to reproduce and have children. And if the woman was not able to have children, I think very few people would ask why and try and help her. I don't know if you've seen the movie that came out on Netflix, Joy, about the first IVF baby, but it just shows you a little bit of background. I highly recommend that everybody watches it. I thought it was a very good reflection of the science behind IVF. It's actually a very accurate timeline of what actually happened with IVF. But it's sad to see the resistance that was there at that time when the scientists were trying to help those women with infertility get pregnant. There was this idea that they're doing things that were not intended to happen by nature, and that we should just let those women never carry their children because just it wasn't happening for them naturally. But anyways, just to show that women's concerns are often not a priority. Women's infertility is not a problem as long as the man is happy. If he has a way to find, children with someone else, then that's okay. And women's pelvic pain never gets addressed. But now women are getting better at advocating for themselves. They're getting better at finding the resources they need to help them feel better. And that's where we're doing a little bit of a better job diagnosing and treating the endometriosis. So compared to 20 years ago, we've made some progress in helping women find the resources they need to find the endometriosis surgeons that can help them get a better quality of life.
And you said this at the beginning that, doctors seem to be normalizing pelvic pain or period pain. And I'm like you, as a health coach, I always advocate for women, or I try to educate women that having intense pain every month is not normal. So please don't normalize it. Just because something's common doesn't mean it's normal. A little bit of tenderness or a little bit of a sensitivity could be okay. But if there's intense pain, especially when related to a topic like endo, where women are experiencing really intense pain, you have to get it checked out. So I guess let's get into that. How can we advise, or what advice can you give to women when it comes to diagnosis? And you said the only way to get a diagnosis is surgery, but what are some steps that they could take prior to that, or certain things they could look out for? And then we can talk about treatment.
I say this every day. Pelvic pain is not normal. Painful periods are not normal. I don't know how many times I need to say this for people to actually listen. And it's not just the general population. We have to remind our colleagues in medicine So the ER physicians, the primary care doctors, the general gynecologists, they are the ones our patients are going to present to first with painful periods. I tell my colleagues, it's okay not to feel comfortable treating pelvic pain. You don't have to. All you have to do is refer the patient to someone who can help them. Instead of saying, oh, don't worry about it, your pain will get better. And I'm a fertility specialist as well. So I have patients who come to see me for fertility reasons. I ask them questions, I dig into their history, and then I realize they probably have endometriosis. So I start asking pelvic pain questions. They get really surprised and they tell me, doctor, you're the third fertility specialist we've seen, but no one's ever asked us questions about the pain. And the reason is because the fertility doctors find it easier to just do IVF, right? So even if you have endometriosis, you have infertility, you're trying to get pregnant, let's fix it with IVF. It's okay if you have pain, you can discuss the pain later or with someone else. You're here trying to get pregnant. I will help you get pregnant. But that's not okay. We need to treat the patient as a whole. If someone comes to you and says they have pelvic pain, they're uncomfortable with their periods, then just ask the questions that may help you diagnose them with a disease that is treatable. So rather than just rushing over it, and I see that all the time, not just with fertility specialists, but also general gynecologists. They tell my patients, just go on birth control pills. It'll help. Birth control pills are great. This way you can become sexually active and not worry about getting pregnant, and it'll help make your periods lighter. It'll help get rid of the pain. But let's backtrack a little. Did we tell our patients why they have pain? What they need to do about it to treat the disease rather than just put a Band-Aid on the problem? Because going on birth control pills is great for contraception, and yes, it may help with the pain, but what's going to happen when this woman stops taking birth control because she's now ready to have a family, or because she has side effects from the birth control pills, or because she's older now and being on birth control pills is risky? What's going to happen then? The symptoms are all going to come back. And so putting women on birth control pills is just a Band-Aid. Getting women to go through IVF to get pregnant is just a Band-Aid. Nothing is going to make the disease go away. The only way to get rid of the disease is to do the surgery to excise it or cut it all out. So it's called endometriosis excision surgery. That is the preferred treatment modality for endometriosis, and it is the only way to give our patients their quality of life back and to get rid of the inflammation. You'd be surprised at how tired patients feel because their body is fighting the disease every day. We have a lot of general symptoms that occur because of endometriosis. Fatigue. I have patients who have just mind fog, brain fog, GI dysfunction. IBS is very common. They feel bloated all the time. It's called an endo belly. They just don't feel well. You go in and remove the disease, and I see my patients 2 weeks post-op, and it's like a light bulb has gone up in them. They feel so different. They feel so energetic. They feel so happy that they now don't have to fight the disease every day of their life. We want to fix the entire overall health of the patient. And what you do with coaching and health and wellness is a very important adjunct therapy to endometriosis treatment. So just doing the surgery, I always tell my patients, is one big part of the puzzle, but it's not the entire puzzle. We then need to work on the things that have been compromised by years of inflammation and years of pain. And it's their mental health, it's their gut health, it's their physical health, their intolerance to exercise or their ability to do more physical workouts. All of that has been compromised because of the years of endometriosis and inflammation that we now need to work on reversing. And it's baby steps. We can't expect a 2-hour surgery to get rid of 10 years of pelvic pain. That's just unrealistic. We start with the surgery and then we work on the other pain generators, the other factors that have been compromised because of the pain that we need to now help undo.
So is a treatment protocol the surgery of and removing, as you say, excising all that endometriosis in the body, in the scar tissue, and then lifestyle and diet interventions and mental health care and exercise and all those things? And then is that it? Or do you see in practice that women have to do maybe 2 or 3 surgeries in their lifetime because that tissue comes back? Does it grow back, I guess is my question. Or is one surgery quite successful and you're done?
Those are great questions. Let's go over the treatment plan overall. So when someone comes in with endometriosis or suspected endometriosis and pelvic pain, I usually like to ask them, what treatments have they tried so far? Interestingly, it takes an average of 10 years to be appropriately diagnosed with endometriosis. So by the time I see my patients, they've already gone through several contraceptive options. They will start with the birth control pill, then I'll see the gynecologist will switch them to an injection, then they'll switch them to an IUD, then they'll switch them to a ring, hoping something will work. It's all the same. We're trying the same modality, the same medical treatment option, which is suppression of ovulation with contraception, and this clearly hasn't worked. So we need to now think of something else or do something else. And that's where patients run into issues, is what else is there available? There's a medication called Lupron. It's a GnRH agonist that puts women in menopause. That's a very common medication that some patients will be offered. But it's literally putting our young, healthy patients into menopause. Menopause is not a syndrome that you want to experience at the age of 30 or 40. It's bad enough when it has to happen in your 50s, but putting women through menopause, in my opinion, is just an unrealistic expectation from that poor woman to go through. So menopause comes with its own side effects: hot flashes, mood changes, dry skin, dry vagina, painful intercourse. All of that is related to menopause symptoms. I have patients who've tried Lupron for 2 or 3 months. They stop the Lupron, everything comes back because the Lupron caused a little bit of shrinkage. While they were in menopause, they felt better because there was no hormone stimulation to those implants, but it's not going to make the disease go away. So then what are we left with? The only other option is surgery. And some patients feel like they have to try medical management before they go on to surgery, whereas others are on board with just doing the surgery right away because the oral contraceptive pills or the patch or the IUD are great ways to suppress symptoms while you're on them. But as soon as you stop them, the pain will come back. And eventually, everybody should go through a surgical excision. But sometimes if it's not the right time, it's never an emergency. It's just to help improve the quality of life. So if they feel like it's not a good time with school, with work, they want to wait a couple of months, that's okay. We can try hormone management in the meantime. And if they feel great on it and they're not ready for surgery just yet, that's okay. But the key is they're not ready yet. Eventually, we have to do the surgery to remove the endometriosis. Excision surgery is different than ablation surgery because there are patients who will go through a surgery to burn the spots of endometriosis. Unfortunately, that is not effective because, like we talked about, first of all, we need a tissue diagnosis to confirm endometriosis, and that can only be done if we cut the tissue out. Second, we cannot determine the depth of that lesion unless we start cutting into it. So if you just burn the superficial part of it, you're not really going to help because the pain and the scarring from that endo spot is still going to be there. And if anything, actually ablating it causes more scar to that area that's already scarred. So we need to excise it and cut it all out. You asked what the recurrence risk is. It depends on the type of excision that you do. If you're really excising the entire peritoneum, which is what I typically do, remember we talked about the peritoneum being the skin of the organs. So if we are peeling off that skin, it's like getting a facial chemical peel where your skin looks blotchy and red for the first couple of days after you do it, but then new healthy skin grows back in its place. It's the same with the peritoneum. We do our excision on the peritoneum, and then new healthy peritoneum grows 3 to 5 days later. That risk of recurrence is quoted at about 20% over 5 years. There's a 75 to 80% chance that your endometriosis is not going to come back for at least 5 years. The studies are very limited. That's why we don't have long-term data, because it's really hard to justify scoping women just to confirm if the disease has come back or not. I like to base it on symptoms. So I tell my patients, your endo is gone. Let's work on the other pain generators. I always have them do physical therapy for pelvic floor dysfunction. If they have bladder symptoms, I have them see a bladder specialist to talk about bladder function. If they have bowel dysfunction, I send them to see a GI specialist, again, to talk about intrinsic bowel dysfunction. And so we work with the different specialties to try and get the pain down to a tolerable level and try and undo the years of pain that those organs have experienced. And if their symptoms come back, they come back and see me. And we do all the workup, we do the ultrasound. We briefly talked about imaging with endometriosis. So I do my own ultrasounds, my own imaging, because there are subtle findings on the ultrasound that can help me determine the stage of endo and whether there's endo in different organs. So the way the organs are positioned, the ovaries, the uterus, the bowel, the relationship to each other can help me understand what I'm going to find at the time of surgery. Even though those patients may have an ultrasound done somewhere else that just says normal, because they're only looking at the organ individually. They're not looking at the relationship between the organs. Not everybody needs another surgery, because that's something else that's a common misconception, is women are told, well, don't have a surgery to remove it because it's only going to come back. and then you're going to need another surgery. But let's think about it. If I do the surgery and I give my patients 5 years of a good quality life where they're not in pain and they're able to function and do normal activities, they're able to take their kids to school, they're able to run a marathon, and then 5 or 6 years later, some of the pain comes back, then I will take that any day over having to struggle with every period for 5 years. And if we need to do another surgery, we do another surgery. It's not a big deal. Women are told that there's scarring that develops from surgery. Scar is very unusual in minimally invasive surgery, especially with an experienced surgeon. It all relates on how you handle the tissue, on how much bleeding and trauma happens at the time of surgery. It's the scarring that comes from ignored and untreated endometriosis that's thick and dense and hard to remove. And so I don't want women to feel defeated when they're told that surgery is not an option because it's only going to come back. That's not true, because you will get a long relief of pain, maybe even never needing another surgery. And for that small portion of women that need another surgery, it still means you got a good quality of life in between the two surgeries, and we can continue to manage the disease as necessary. It's the same with, for example, Crohn's disease or ulcerative colitis, when women have to have part of their colon removed, and then we evaluate their symptoms, see how they do, and they may never have to need another surgery, or they may have to have another segment of their bowel removed later, but no one ever tells them, oh, don't have that for surgery because it come back. Because we know that the disease needs to be treated that way, needs to be treated with a colectomy or a partial bowel resection. And so the same courtesy should be extended to endometriosis patients. We know the disease needs to be excised, we know we need to cut it out, and if it comes back, we'll deal with it when the time comes.
Is there any advice we can give to women who want to have a successful surgery and a post-op experience, and they want to avoid having another surgery? Like, for example, is sugar implicated with endo? Because I know sugar and fibroids, there's a very high maybe causation correlation with sugar and fibroids, because I know that this is all related to hormones. If we're not eating right, or we have too much sugar, or we put too much demand on the liver, then the liver can't properly detox our excess estrogen. Or if there's progesterone dominance, I'm not sure. Or maybe too much stress, if we're stressing ourselves too much with not just our lifestyle, but maybe with our exercise, and then cortisol spikes, or too much cortisol in the body, or extreme fatigue. Is any of this implicated when it comes to endo? Because I do know it's implicated when it comes to hormonal imbalances in women, and even PMS symptoms, menstrual issues, and fertility issues. But I just don't know if it's implicated with endo, and if there's anything we can offer women who've had a surgery and just want to have the most successful post-op experience.
That's a great question. First of all, just to start with the surgery itself, I would say do your research and find an endometriosis specialist that is comfortable excising and treating all the disease, because that's the biggest challenge. There aren't a lot of endometriosis excision specialists across the world, unfortunately. Even here where I'm practicing in California, excision surgeons are not that frequent. And a lot of the general surgeons or general GYNs who say they do excision surgery are not trained to treat or manage advanced endometriosis. So number one is do your research. Please do a lot of reading about the surgeon you're going with for the surgery. Make sure they are comfortable excising endometriosis, and make sure they have been appropriately trained to treat endometriosis. So not all minimally invasive GYN surgeons have endometriosis experience. Not all reproductive endocrinologists and fertility specialists have endometriosis experience. So make sure you find a surgeon that you're comfortable with, because you will have to trust your surgeon to guide you on what to do next if your pain is still there, right? If you still feel like you're having symptoms after surgery, you don't want someone to say, well, maybe there's residual endo. Let's put you on hormones. You never want that to happen. You want the surgeon to be confident that they've removed and treated all the endometriosis, and they're comfortable leading your treatment where you may have to see other specialists in the area, depending on what other symptoms they think there is. But when it comes to diet, there is data to show that an anti-inflammatory diet can help improve pain. So cutting out all the inflammatory products, like you said, sugar, carbs, alcohol, smoking, a lot of those inflammatory products can cause the endometriosis symptoms to flare if the endo is still there. I have patients that ask, will an anti-inflammatory diet make my endo go away or decrease the chance of it coming back? We have no data to support that. But I do highly encourage my patients to find a diet that works for them. For some women, it may be a gluten-free diet. For other women, it may be a lactose-free diet. For others, it's a complete anti-inflammatory diet. Everybody is different. But if you don't feel different on the diet, it means it's not really doing much for your symptoms. And you can stop restricting your diet as much and try things that you enjoy. But the goal is to lead a healthy lifestyle because we don't know what triggers the endo to come back. And we want to give our patients the best chance of not having a recurrence, but we have very limited scientific data or evidence to support certain diets for endometriosis and pelvic pain.
And just because, of course, I'm a health coach, when you say carbs, you mean refined carbs.
Correct.
Okay, just
You know the
people,
terminology.
I want people to hear that because when you say carbs, people hear go ketogenic and they think all
No,
carbs
that's
are
not what
bad.
I
And
meant.
yeah,
Absolutely not. We have to know our limits. I'm only a GYN surgeon, so I'm a fertility specialist and a mixed surgeon. I know what I know, but there are so many things that I don't know. And so I will not recommend certain diets for my patients because I don't think it's my specialty. And I'm sure there are a lot more smarter people out there that know a lot more about diets. So I have my referral circle and I will refer patients out to specialists so that they can get the most educated answers and the best quality care that's available in that field.
I'd love to ask you if there is an endo gut health connection. Have you come across this in your practice?
Yes, 100%. So, a lot of women with endometriosis may also have other GI issues, and I work very closely with my GI colleagues to refer patients to them because a lot of them have motility issues. So, the gut, the way the bowel moves, is affected by those inflammatory deposits that may not be on the bowel itself, but around the pelvis. As that bowel is rubbing against those endometriosis implants, the bowel motility is affected. And then SIBO, small intestinal bacterial overgrowth, is very common in women who have endometriosis. And so if they have bowel symptoms, I always make sure that they get evaluated for SIBO because that may need treatment. And this is where diet plays an important role. We don't want to just treat the infections with the antibiotics because it is bacterial growth, but we also want to make sure that our patients are maintaining a healthy diet to reduce the chance of that bacterial overgrowth happening again.
Why is SIBO and endometriosis connected? Why do you see this in endo patients?
Again, it's really hard to pinpoint the exact reason, but we think that endometriosis has an autoimmune component to it. That's what creates a lot of the inflammation, and that's why it's associated with other autoimmune diseases as well. But when it comes to the SIBO, it's probably related to gut motility as well. Because, like I said, the motility is affected. There's more chance for that harmful bacteria to grow and overtake the bowel.
I'd love to ask you about how endometriosis impacts fertility and what are some treatments that women could look into if they are trying to get pregnant and maybe they can't do the surgery or they've done the surgery and if the surgery impacts their fertility as well.
Alia, this is my favorite question because I'm a fertility specialist. So I'm both a minimally invasive GYN surgeon and fertility specialist. So endo and fertility is definitely my favorite topic to talk about, and I could talk about it all day. But I just want to highlight the important connections between fertility and endometriosis. So, number one, not everybody with endometriosis will have infertility because, again, sometimes women are told because you have endo, you cannot get pregnant. That is untrue. 70% of women with endometriosis will get pregnant naturally, but 30% of women may have infertility related to the endometriosis. That's number one. Number two, will pregnancy make my endometriosis go away? When you're pregnant, it's a high progesterone state. So the progesterone in pregnancy is suppressing ovulation because when you're pregnant, you're not ovulating. And that really high progesterone that's produced throughout the pregnancy can really calm down those endometriosis implants. Or after delivery, some women, some and not all, may not have pain anymore because that prolonged exposure to progesterone, possibly breastfeeding because that suppresses ovulation, that can give your body a break. That can give those endometriotic implants a break where they calm now and your periods after delivery may not be as bad. Some women will have the pain come back right away, and others, it may take a couple of years before the pain comes back. And in some proportion of women, they're older, they're closer to their period stopping altogether, their pain may never come back. However, it is only a small percentage of women that will feel a lot better after pregnancy. The majority will have the exact similar symptoms they had prior to getting pregnant. Now, how do we help our women get pregnant? Is IVF the only way? Interestingly, if we were to do IVF with the endometriosis still present, our pregnancy chances are reduced. So we shouldn't be offering IVF to patients we know have endometriosis unless they're older or they have a low egg count and we're worried that time is a factor. But if they're young and they have an appropriate number of eggs and they may have unexplained infertility, because that's again a very common category with our endometriosis patients, is everything is normal, no one's able to figure out why they can't get pregnant, and they get bundled under unexplained infertility when in fact endometriosis may explain their infertility. So if they have endometriosis and they're young and healthy, if we were to do surgery to just remove the endometriosis, about 30% of those women will get pregnant naturally. So not everyone who has endometriosis automatically needs IVF. We should, if the woman is young and has an appropriate egg count, we should counsel them appropriately that surgery can help remove the inflammation, help decrease the pain, and may help them get pregnant naturally where they may not need IVF. But if there are other factors like poor sperm or the woman is older with low egg count and we really need IVF, then we need to consider the surgery as well, because removing the endo can help improve outcomes from IVF and can help increase pregnancy chances with IVF. And there's a lot of good data published on this. So women who have unsuccessful IVF cycles, so they've tried IVF, they do transfers, they don't get pregnant, we suspect endo, they have surgery, they get their endometriosis removed, those women can get pregnant naturally without even IVF. But if they continue to do IVF, their outcomes after excision of endometriosis is going to be better than their outcomes without excision of endo. So my message to all those women who are trying to get pregnant, if you suspect you have endometriosis and you've already gone through a couple of IVF cycles and you are unsuccessful, please don't keep trying the same thing because the results will be the same. Find an endometriosis specialist, talk about the possibility that endometriosis may be affecting your outcomes, and see what we can do to help in terms of surgery and getting rid of that endo before we continue our IVF journey.
Is there a long wait after the surgery that they have to, endure in terms of recovery? Is it like 6 months? Is it a year until they can try again?
It's 6 weeks, Alia, only 6 weeks.
Oh, great.
So IVF is very personalized, so it depends on a lot of factors. But in some women, we will retrieve their eggs, create the embryos, make sure we have those embryos to transfer after, then do the surgery to remove all the endometriosis, and then 6 weeks later, transfer that embryo back into the uterus. So you really need to see a specialist to come up with a plan because there's no one size fits all when it comes to endometriosis management and fertility. But it's very important to have a fertility specialist that understands endometriosis. Because, as an endosurgeon, surgeons just want to cut things out. An IVF doctor just wants to do IVF to fix everything. But we need that balance in between where we understand where surgery is necessary and where IVF is necessary. And sometimes have a blend of the two where we do a part of the IVF cycle, then surgery, then the second part to transfer the embryo.
Dr. Sadikah, this has been an incredibly fascinating conversation. Really, thank you so much for your time. I'm sure there's a lot of women listening to this that are super appreciative of all the information you shared. Are there any last nuggets of gold or wisdom or pieces of advice you'd like to leave the listeners with that I haven't asked you regarding this topic?
I think that you've asked all the important questions, Alia. I just want to remind my female audience to please advocate for themselves. Please don't let anyone tell you what's normal. If you feel like your periods are just too uncomfortable, they're restricting your activities, they're preventing you from doing the things you love doing, then that's a red flag that this is not normal. Find someone who listens to you. If your first 3 gynecologists dismissed you, it doesn't mean that there's nothing wrong with you. It's never going to be in your head. So find a surgeon that will listen to you and that will give you solutions to your problem. And please don't give up on yourself, whether it's fertility or pelvic pain or both. Please don't give up because there's always going to be a way for us to help you. You just need to find the right team. If anyone needs to see me, I'm happy to see anyone. I'm located in California, so I may be far for some of your audience, but I always offer Zoom consultations. So if anyone feels distressed and they haven't been able to find the right answers for them, I'm always happy to provide a consultation via Zoom. But for our patients who are looking for surgeons or physicians that are closer in their area, I always recommend a resource called Nancy's Nook. So Nancy _S and then Nook is Nook. Nancy's Nook is a Facebook page that's dedicated to endometriosis patients. Nancy is a nurse who I know very well myself. She's a very well-educated nurse who unfortunately had to suffer through endometriosis, and she saw the inaccurate information that was being shared on the internet. And so she created this platform for education. It is not a blog. It is not where patients just talk about their experiences. It is an educational resource where you can review scientific-based articles, videos, lectures, podcasts similar to this one. So a lot of information from surgeons that have been vetted. So surgeons that we know are experienced and comfortable treating advanced endometriosis. She even has a surgeon list. So if you go on her Facebook page, and it's a closed group, so you have to say why you're there. You can always say your doctor recommended joining the group. You can put my name in. You can say you're just here for more information. She just wants to make sure that women are there to really gather scientific evidence on endo. And once you join that group, she has a list of recommended surgeons that have been vetted. So surgeons that she has talked to, surgeons that she knows their training, and that patients have had good feedback from. And they're all over the world. Obviously, it's not an inclusive list. I'm sure there are more surgeons that are not on there, but I would say it's a pretty good list to start with to see if you can find an endometriosis surgeon in your area that's experienced with advanced endometriosis. But unfortunately, I have to add, a lot of patients have to travel. Even here, I'm in California. I have patients coming to see me from all over the country. And we're in the United States, where we think that we have the best healthcare. But when it comes to endometriosis, unfortunately, there are very, very few experienced surgeons. And so please keep in mind that you may need to travel to get the appropriate care. But if it means traveling to a country where you have friends and family in the area, then I would recommend you consider that, just because it's so worth it to get your quality of life back.
100%. I will link all those resources below. I will also link your website or links that are associated with how people can get in touch with you once you share all that information with me. Dr. Sadikah, again, thank you for your time and thank you for sharing everything you did with us today.
You're very welcome, Alia. Thank you so much for your time. I appreciate it.
Thank you for listening. Please share with family and friends that you feel could benefit from this episode, and make sure to hit that subscribe button and leave a rating and review to support the show. Check out the links below for more information about my guests and where to find them. And make sure you're following me on Instagram at wholesome_practice to learn more about what I do. I appreciate you being here and see you on the next one. This podcast is for educational purposes only and should never replace the advice of your doctor or physician. Always consult a medical professional before making any changes or adding anything new to your diet, lifestyle, or medication protocol.